who make points just to basically put down something that's really cool and exciting, okay? Like my Kumbaya moment here. But no, no. The only reason
Well,
why,
and that's pretty bad if I'm considered a hater because I'm usually considered one of the extremists on the other side.
no, no, no.
Think,
I'm not saying that you're a hater by any means because um, the point is, and again, this is something that I am going to look at after we have this little discussion here, or maybe somebody in the audience can look at it for us. Um, some of those studies actually did control for that, where they had control women who had kids, even four. I'm pretty sure I remember seeing this because I think there was one that had four kids, four male kids, and I was thinking about my mom because my mom had four male kids as well, and she didn't have any male cells in her. But you're absolutely right. It is a very controversial area, without a doubt. I just think that yeah, we need good science. But that brings a
I mean,
very
the thing is, Tom. I mean, it's being just agnostic about it for a moment. I mean, it is as Amit has suggested a legitimate concern if these cells are migrating where you don't want them. And for the most part, we think of these cells as being benign, and cell therapy sort of in general as being other than the concern, at least adult stem cell therapy, being largely, for the most part, we perceive it now to be generally, at worst, benign. And yet, if these cells are migrating to places where we don't expect them to be or we don't intend them to go, then who knows what the long-term consequences. We can't, it's hard to imagine that they're going to be that dramatic or drastic, but we don't know. And certainly from the FDA's perspective, which whose mandate it is to protect the public, they of course are concerned. They're very interested to see this kind of data, and the great one of the issues with cell therapy to date is that we are, for the most part, simply observing what happens to the patient after we inject these cells. It's a great mystery to us what happens to these cells for the most part after we engraft them, unless we're able to do in animal studies histological sampling and things like that, which is why there's a tremendous amount of energy being poured into in vivo tracking models right now. So I'm working, for instance, there's been a number of groups outside of the United States and Europe and South America using iron oxide particles, for instance, loading the cells that can so that then those cells can be imaged by MRI, for instance, or genetic reporters, which have their own sets of complications, with respect to what they do to the cells and that sort of thing. But I'm working with a group that's using fluorine-based nanoemulsions that they are poised to start their first clinical trial where they can label the cells with what appears to be, in all the studies that they've done so far, a benign nanoemulsion that can be that is imageable by MRI. And then for the first time, at least in the United States, you can actually begin to track where these cells go and quantify them and be able to make scientific and clinical assessments based on that information.
no. That's a very, very important point. But let's go back really quickly because this is an area very close to my heart, which is the fetal to maternal trafficking and vice versa, maternal to fetal trafficking. Couple of reasons why it's close to my heart. First of all, when I joined Medistem, one of my original conversations with the founder, Neil Reardon, was at that time there was a lot of work being done by Medistem using non-matched cord blood CD34s. And my initial reaction was, oh my God, you're doing this, you're going to be getting graft versus host disease. In the worst case, in the best case, you're just going to get these cells cleared by the host versus graft. And then Neil said to me, he said, Tom, there is the fetal to maternal trafficking, which you mentioned, Amit. And I said, yeah, Neil, I'm familiar with that field, but a lot of those papers, they actually show that when the mother is injured, it's the fetal cells that are contributing to the injury process. And then Neil said, well, how do you know they're contributing to the injury process and just not going there in response to it to try to heal the injury process? So what we did is we sat down and reviewed the literature. And what came out was some very interesting, and this is published, what came out with some very interesting things which we didn't know about. Number one, there are studies in which you take a GFP male and you breed it with a wild type female. So you have a green mouse father and the mother is wild type. The offspring has the GFP in it, the green gene in it. Now the offspring is putting in these cells into the mother, right, because of this fetal to maternal trafficking. When you give the mother a stroke by ligating the middle cerebral artery, the fetal cells actually engraft and start differentiating into neurons, contributing to repair. So there's some very, very interesting studies, and yes, the cells. Lee Nelson, I believe she's from Seattle. Lee Nelson has done a lot of work, published a lot of work on this, and has shown that in patients, in women who have scleroderma, the autoreactive cells in scleroderma are from offsprings that she had 20 years ago. So it's a very, very interesting field of this maternal fetal trafficking, and also the flip side of the coin, which is the maternal to fetal. When you take, this is work done at University of Guelph by a close friend of mine, Anne Croy, Dr. Croy, who's Canadian. She's at Queen's now in Kingston. She found that when you transfer a wild-type embryo into a GFP mother, actually she was using the ROSA system, LAC-Z, so it's a normal embryo, you put it into a mother in which every cells in the mother are stained, and then you sacrifice the embryo. Guess where the mother cells go into the fetus? Guess which organ? Take a guess.
Brain.
Close. Lee, you want to hazard a guess?
No guess. No guess.
Very, very bizarre. In the thymus and in the bone marrow. So there's actually, people have reproduced this and have taken this work even further, but there's actually some concepts that the mother somehow pre-programs the infant through her immunological experiences and so on. So anyway, cellular trafficking is very, very cool. Lee, what was your Kumbaya moment for the whole field of regeneration?
Well, I was sort of hoping you were going to come back to me. I'm much more of a follower in this field than that, I guess. I mean, I've been in the field for 10 plus years, but it feels as though, I took a back door into it, and in many ways, I think the field was already there. I mean, as I understand it, it was really this business of us using stem cells to reconstitute immune systems and discovering that these stem cells could differentiate into other kinds of tissues, and it just opened up the floodgates into imagining that, well, if you can use these stem cells to create almost any kind of cell that you can imagine, then there's a tremendous amount of potential. And what has exploded, I think, over the past, I think even just 4 or 5 years, is that there is research going on using cellular therapies of some sort in almost any kind of condition you could imagine. There's, of course, the big market disease indications like cardiovascular disease and diabetes, but it trickles all the way down to very simple systems like cartilage and skin repair and very niche diseases which we have absolutely no treatment for, which we think we might have a new model for treating. Obviously, it's under clinical investigation, and we have yet to figure it out.
You saw a recent paper on erectile dysfunction, right?
Yeah.
I mean, that's one area which I think has a lot of application. What, 30% of males are resistant to Viagra, or do you know the numbers, Amit?
No, but it may be up to that number, and it's great that the whole concept of sildenafil has really helped the field to kind of advance not only the drug therapies, but kind of in your case where you are doing nutritional therapies, but even cell therapies. We see that one of these cell therapies that we may use for cardiac or vascular disease, that it is not uncommon to see that as a side effect, that as some of the patients have responses, one of the responses is that they have a change in a positive way in terms of their erectile dysfunction. So
in fact, doesn't it work the other way as well, Amit? That in fact erectile dysfunction is often a predictor of cardiovascular disease.
Oh, it is. It is. It truly is. Combination hypertension, diabetes, cholesterol. That erectile dysfunction is not uncommon in patients who have, especially that combination of all three. And so, as you may see some of these biologics start working, that's one of the early functions that starts returning back to normal, is they do have an improvement in function. There are specific therapies where people have delivered them directly to the vascular bed, and they have seen the same effect.
Now, who's doing the guys in
fact, I think I read a paper recently. I can't remember who it was by, but they took a set of patients who were they thought were likely candidates for cardiac disease of some sort, and they took the subset of that patients which had erectile dysfunction, and it was remarkably predictive, like upwards of close to 100% of the onset of I think AMI within a relatively short period of time.
Yeah, we cite in the paper. We cite a lot of those studies. It's very interesting. But let me ask this question. How far are we in terms of bone marrow or any of the angiogenic therapies for erectile dysfunction? You guys, the guys in Germany, the Excel Center, I think they were advertising something about that. You guys know anything about who's doing well work in that space?
Ironically, I'm not aware of any formal trials for erectile dysfunction, actually, but maybe Amit is.
No, as a primary treatment, there aren't any specific trials. There are certain clinics around the world that are advertising for it, but a lot of the secondary endpoints for our trials do have that as a function of vascular disease, and I think we'll really start seeing it as a lot of our phase 3 critical limb ischemia trials are up and running in the U.S. and Europe, that as those start getting approved within the next 2 years, that would be a next very straightforward step to get into, because it also falls under the relatively lower risk population of patients that are already undergoing very high risk therapies. So just seeing it as maybe some of the secondary endpoints and a lot of the critical limb ischemia and cardiovascular cell trials, I think that it may be able to advance much quicker once one of them get up and running in the phase 3. But until then, as an isolated program, it just doesn't exist yet in the U.S., and you think it would, considering the amount of disease and the potential market.
No, I
just typed erectile dysfunction and stem cells into clinicaltrials.gov. I got one study in France, and it's for post-prostatectomy erectile dysfunction, and they're using bone marrow-derived mononuclear cells. But that's it.
Wow, no, this is excellent. I'm surprised that Chris Centeno isn't doing autologous fat for the erectile dysfunction. I mean, he wouldn't have to expand the cells then, right? But no, it's a very interesting field. How we got into it was the same kind of situation we observed in some of the patients we treated in Panama. Intramuscular injections of the bone marrow, and they started having a better erectile function. We filed the patent on that about 4